Good afternoon, everyone, and welcome very much to this new webinar from the webinar series dedicated to artificial intelligence. Today, we're going to discuss artificial intelligence ethics and its implication. I'm really happy to be with all of you today, and I see that you are quite a lot of people and constantly growing, so this is really, really exciting. My name is Elena Balestra, and I'm head of governance, membership, and capacity building, and really excited to be with you and to discuss this very intriguing and complex topic. So before getting into what we're going to discuss today, I would like to remind you, although by now you're all very much experts of GoToWebinar, how to best enjoy the webinar and how to interact with us along the webinar. You can chat with us and ask us any question related to the content of the webinar in the question panel that is on the right side of your screen. And you can write the questions in any time, and we will take a moment during the Q&A time to answer to hopefully all your questions. And if you, on the other hand, have any technical issues, you can use the chat. And very kindly, we have today Michele Calabro, our policy advisor, who is going to take care of managing and moderating the chat and the discussions. So obviously you will receive afterwards the recording of this webinar, either if you are participating now or if you just registered for the webinar, along with the first episode dedicated to what is it really artificial intelligence and what are the implications in healthcare. What are we going to discuss today? Why patients do have to take an interest in artificial intelligence and its ethical implications, what is really at stake, and then, as I was saying before, we will have a moment to for you to ask us several questions on this topic. And I really remind you that at least from EPF side and the staff, we are all very much new to the artificial intelligence topic in healthcare. So there is really no silly questions. And this is really a moment that we created to learn and to shade some lights on a complex and very new topic for the patients community. So don't be shy and really take the time to ask any question, even the silliest that you can really think and imagine. It's not going to be a very silly question, I'm sure. So obviously, I'm not going to be the expert today, but we very much happy to welcome Professor Heidi Mertes, who is an associate professor in medical ethics at Ghent University, and she's going to be actually the person answering a few of our questions. As I was saying, she is associate professor in medical ethics at Ghent University, and she teaches as well bioethics, medical ethics, moral philosophy, and global health ethics. Her academic research focuses on ethical implication in healthcare innovation. So it really sounds that we are in perfectly good hands to discuss about artificial intelligence and its ethical implications. Heidi, I kindly ask you to turn on your camera.
Oh, I thought it was already turned on. I can see
it's just that I'm having too many screens open at the moment. So if you are, I'm sure people can see you. So welcome very much.
Thank you, Elena. I'm very happy to be here. Thank you for inviting me for this exciting webinar, I hope.
Excellent. So we have a few questions for you, Heidi, actually, that were put together by our members and our team. So I hope you're ready. And
yes,
excellent. So we can actually start with the first question. So why do patients need to ask themselves questions about the ethics of artificial intelligence?
Well, I think it's very important to ask those questions because we tend to think about AI as something futuristic, something far away, but actually we encounter AI in our daily lives already on a daily basis. If you've used Google Maps, you've used an AI-based tool. And so also in healthcare, there's more and more AI, and I think there are a lot of expectations, but also a lot of worries around AI. There's very much this balancing of benefits and risks. And I think especially in healthcare, because the patients are the people, that we're trying to help in healthcare, and it's all of us eventually. So I think this implementation of AI is something that really concerns everyone, and that many of the risks need to be approached, beforehand. We don't have to wait until the applications are all ready, and then we start thinking about how should we implement it, because then it's going to be too late. And I think or in general, researchers and scientists realize more and more that it's important to take the patients into the project from the start, so that we know what the concerns are, what the worries are, what perhaps the wrong perceptions are, or the right concerns, and so that we can kind of reinforce each other. And I know that you already had a talk last week or last webinar about the benefits, but I made a slide just to show you what the benefits are and what the risks are, just in big lines, that I think patients should be at least knowledgeable about. So I have two hypothetical patients, let's say. So this is patient Thomas, and he has a number of ways to use AI to make his healthcare better. So this is, let's say, the best case scenario, and what AI can do for us. So Thomas has a smartwatch, and that enables him to take some preventive measures. So his smartwatch will give him information about about his health status, about oxygen saturation or heartbeat, or and that can enable him to let's say to take care of his own health, to take charge of his own health, and to try to prevent becoming ill. So that's the prevention part. And then also in terms of diagnostics, he may benefit from AI. So for example, he might on his phone have an app with which he can scan the pictures that he took of his little daughter that you see there. And for example, the app that I took here as an example is one where you can just let it go over all the pictures you have on your phone, and it will detect which, if there are eyes that reflect, it's the white eye reflection, as they call it, reflects wrongly. So, and if you see a white dot, then it might mean, not necessarily, but it might mean that there's an eye cancer there. And if you detect it early in small children, then you can start treatment earlier, and you can prevent the child from becoming blind. Whereas if you would wait until you would actually have symptoms, then you would already be much further down the road, and it will be harder to take preventive measures. It's not going to give a diagnosis, but it might, if he lets the software run and he sees, oh, it's always the left eye that reflects differently, then he might take this information to go to his ophthalmologist and ask him, should we be worried about this? And then also, so that's the diagnostic phase. And then also in the clinical phase, let's say if Thomas gets ill, he has to go to the hospital, then his physician can use clinical decision support tools to look at what did patients that looked like Thomas that passed by in the clinic before, what problems or what outcomes did they have if they had the same symptoms, and which treatments did we give them, which one worked best, and then we can give the same treatment to this patient. So these are I guess the benefits that we are all hoping for that AI will bring. Now we can also look at Maria, for example. So Maria is also a patient or potential patient. And she might also like to have all these benefits, but she might encounter some problems. So it might be that her smartwatch or some app gives her advice, but it doesn't really explain to her how they came to that advice. And she's perhaps not sure why she should be taking certain measures, or why even in the further down, if in the treatment phase, her physician might even think like, why is my clinical decision support system giving me this recommendation? I don't really understand why for this patient it would be a good advice. So that's what we call the black box problem. So that's one concern, that if even the physician perhaps doesn't really understand how the AI tool works, then it's difficult to get an informed consent also from your patient, because you cannot inform them if you don't understand yourself. Or Maria might have a different problem. She might also use an app that she has on her phone to do some screening. For example, she might have some spots on her skin that she wants to, find out if they are worrisome. But Maria has a darker skin tone than the pictures that were used to build the algorithm, and it might not detect correctly for her skin tone what the implications might be of certain spots she has. So whereas this app would have been very predictive for Thomas, it might not be so predictive for Maria. And Maria might also be worried that if she is uploading all this medical information into the hospital system or on her phone or wherever, that this information might be sold. So she might have read in the newspaper that Google and Apple are combining their information with information from hospitals. She might be worried that maybe her health insurance might get access to this information, that her employer might get access to this information. So although the way it is set up, all these AI tools are set up with the best intentions, there might be drawbacks as well. So that's a long way of saying I think it's important for patients to at least think about this and know what the concerns are.
Excellent. And diving a bit further, I think now we have a moment to ask actually our participants what they think about it and how they feel about artificial intelligence in medicine. So dear participants, we are launching a poll so that you will shortly see on your screen, and you have 3 options. So you can be mainly hopeful, excited, mainly worried. You can be not sure, which is absolutely fine, because this webinar is really to give you a bit more insight on this topic. You have around 30 seconds to answer, and then we'll share the information, the results with all of you. And talking about data, obviously those are anonymized data, and we're not going to use them afterwards.
Yeah, I think it's just interesting for us to see what the gut feeling is of many patients. If in general people are, if they are really hopeful and looking forward to all this AI, or if they are maybe already alarmed by information about concerns.
Absolutely. And Heidi, I will show the results. I think we're good to go. Let me see if I can. Nope. Okay. And I close. And okay. Nope. I will tell you. I will tell you exactly how people voted. I hope to be able to share the results, but apparently no. So actually, we are looking at the bright side mainly at EPF. So 79% of the participants are mainly awful or excited. 25% are not sure, and say 6% are mainly worried. Yeah. And in total, 64% of the people that are online voted. So voila, that's a good
response. Yeah. Okay, so thank you. That's interesting to know. I think it's, well, I'm happy that everybody is positive, because it would be a pity if people would turn their backs on AI because of the concerns, because it really has a lot of potential. Also in terms of accessibility of healthcare, it really has the and our healthcare expenditure has been increasing for year upon year, and there might be some solutions that AI may offer that would really make also for low and middle income countries to make healthcare a lot more accessible, and that we shouldn't forget about when we do talk about the concerns. So of course, this is the ethics talk today, so I will be talking more about the concerns today, but please know that it's not to scare you away from AI, but just to make sure that we can implement it in a way that enables us to have the good sides of AI without having the drawbacks. So to give you some hints on what we may do to make.
Absolutely, and I think we're really at the right time for having a conversation in really, while patients are going to be involved in those type of conversations, to know what to look for and what to be worry or mindful about, and not to be completely fascinated by a tool, but on the other hand, to be fascinated, because this is partly the future. Which, talking about, what are for you, Heidi, the 3 key ethical challenges in the use of artificial intelligence?
Yeah, well, the 3 that I selected, let's say, or I think the black box that I already shortly referred to, and then bias, bias in healthcare, and also the way data is being handled. So data sharing, secondary use of data, and gathering of data. So I'll shortly say something more about each one of them. So I already told you that the black box problem is a problem where we don't really always understand how an AI works, how an algorithm works, and that can have negative implications in the sense that it might be that an algorithm is actually giving wrong advice. And I think you had some examples of that also in the previous webinar, where you don't necessarily understand why. I think the previous speaker gave an example of hiring policies, for example, where if you put in resumes of all males that are good employees, then the algorithm will probably use, especially if it's machine learning, it will use as a criterion male or female, even though if you would know this, you would say, but that's, we know that criterion doesn't matter. But if you don't know, if it's a black box, then you can't take it out. So what's very important in that respect is that we have explainable AI. This might be a concept that you've heard about. So because if we can explain how an AI came to a certain solution, and you can, there are more and more tools to enable this so that the AI can, let's say, explain itself, then you can also pick up biases and take them out and make the system better. So this is something that I'm personally rather optimistic about. Maybe, well, we'll see what the future. Maybe I'm being naive, but it seems to be like it's not an insurmountable problem, but it is a very important one. We should really be paying a lot of attention to it, I think. And then that brings us to the second one. They're all kind of interconnected, the different concerns. But which is bias, and I'm guessing that you already heard at least a bit about this. But we tend to think that AI systems are very neutral and very objective because it's a computer. It's not a person with pre-implanted ideas about certain groups of people. So we think, it's neutral, it's good, and it's fine. But as you already know from the example I just referred to, if you input certain biases already in the system, in the algorithm, then the output is going to have those same biases. So that's one way how an algorithm may be biased. It's, what you put in comes out. But also, even if you don't, it can be more subtle than that, in the way that even if you try to take out the bias, let's say that you have a system in healthcare and you want to be cautious for bias, so you take out the data that refers to ethnicity, for example, and you think, that solves the matter. Now the algorithm doesn't have information about ethnicity. Well, chances are that if you live in a society or in a city where people with certain ethnicities live in certain postal codes, for example, that the AI system may start to select on postal codes. So, for example, I think this is the example that is on the screen now, but I will go into it later. But there you had it's a clear example of where Black Americans, so African American citizens, received worse healthcare. And even if you would take out the ethnicity, it will still find those people based on postal code. So it's a very tricky thing to curate, I guess, to take it out.
So in a way, you're saying that if the society is biased, obviously the society is feeding the machine somehow. So it's like it's a human problem more than machine itself, right?
Yes, yeah, and oftentimes we think because we're in a, in the age of big data, so we think, oh, but just put as much data in there as we can, and then it will be very diverse. Then we will have all kinds of data, so then it won't be biased. Like the example of the recruiting, that wouldn't happen, we would think, if we would have lots and lots of data that we put in. But that's actually not necessarily true, because you will still, percentage-wise, have a bigger representation of certain groups. And I will also show examples of that, how especially, for example, in healthcare-related AI, oftentimes it's the people with a Caucasian background that are very well represented, and not so much people of African ancestry. And then we come to the data sharing as well. So there, well, we have a lot of concerns or questions about what happens to the data. So especially if several data banks are being linked to each other, then you can gather a lot of information about a person. And I think we've gotten a bit accustomed to that due to social media. I think at the beginning, first time when you got a personalized ad, you were thinking, oh, how did they know I was looking at that website, looking at clothes, for example, and now I get all these pop-ups with advertisement. But it's I guess maybe it bothers us less because we think, oh, it's tailored to us. But at the same time, I think it's still it does mean that certain companies are able to connect many data points and get really a lot of information about a person based on this data. And as long as it's where I'm shopping, I might not mind that much. But if it's about my personal health, then I might mind a lot more, because of concerns of, for example, what if my health insurance or what if my employer gets a hold of my my medical information. Also, reuse of data for research, for example, is very valuable. So we really have to find a way to share health information, health data, so that we can have high quality research and high quality treatments. But it also means that we have to be careful to shield off this information from people that have no business looking at our medical records, so to speak. So that would be the three main points for me.
Excellent. And just talking about data, as you say, does data anonymization solve all problems related to privacy when it comes to artificial intelligence and data?
No. So that's an important thing to realize, because in the past, when research, for example, on data, you could just say we anonymize it, and then we don't have to worry about people being harmed by what happens to the data afterwards, because nobody will be able to trace where it comes from. But this is becoming really difficult because of all the big data research. We have so many data points, so many data banks that we can connect. And there have been several studies demonstrating this, that if you only have a couple of pieces of information of a person, if you go online, you can find who they are. So it's important to realize that this is not the only problem. So we will need other solutions to solve that problem. For example, there have been ideas like the solid technology introduced by the inventor of the World Wide Web, where my data would stay mine, and if somebody wants to use it, they can kind of use it, but in a way that I don't really have to transfer my data to a Facebook, for example, or to a hospital in this case. Also, only using or only transferring aggregated data, for example. So that's what a hospital might do. They preferably wouldn't give my personal patient record to a researcher, but what they might do is say, well, in our entire hospital, that percentage of people have this disease, and that wouldn't say something about me necessarily, if they don't add too many data points, that is. And then also oversight. So the reason why we would want to anonymize would be to protect people, but we can also make sure that there is some kind of oversight, so that, for example, employers or health care insurers cannot use this kind of data for certain discriminatory measures, for example.
Excellent. So next question. What are the implications of replacing human judgment for clinical care?
Yeah. Well, first of all, and I think I also concur with the previous speaker there from the previous webinar, I don't think we are going to a place where you won't see your doctor anymore at all, when, like the way you're talking to a chatbot sometimes now when you're trying to get some customer representative somewhere, that you will be talking like that to a chatbot as a physician. I think the last speaker pointed it out very well, or worded it very well by saying artificial intelligence has little emotional intelligence, and we need that emotional component in our physician-patient relationship, at least for the majority of reasons why we visit our physician. So I don't think we will ever have a complete replacement, but we will have a partial replacement in the sense that, for example, clinical decision support systems based on AI will help our physician make better judgments for our care, and it will, in a sense, be a great tool for them to use. So it will give them the, let's say, the superpower of knowing everything that's published on a certain illness and of going through thousands of patient records, whereas now your physician perhaps only saw 20 patients with the same disease that you currently have. So that's all. Those are all, I think, positive implications. But I think it is very important that we keep stressing that we do need the human link still in there somewhere, so that we don't let it kind of, you know, spill over into something that is complete reliance on the AI technology. Because I think oftentimes, well, it's artificial intelligence is on the one hand very smart, very good at doing a very specific task, but it's not very good at doing a complicated task. And healthcare is complicated. It's always people have every patient is different and has other values, other aspirations, other concerns, other, you know, another family situation. So there will be implications, and we should hope that it goes towards better clinical care. But we have to make sure that, I think, that we keep the human in the loop to avoid certain mistakes. And that the physician understands, of course, the clinical decision support system, as I said before, so that they can correct it where necessary. And I realize that this will not always be easy, because sometimes a physician, you know, will kind of have to choose between his intuition or her intuition and the AI system's intuition, well, or judgment. But it's good to have both. I think as long as we have both, they can correct each other, let's say, or reinforce each other. Also, the reason, maybe one example I can give why of a case where this replacement of clinical judgment by an AI turned out to be not so well thought out of was a system introduced in hospitals to monitor for sepsis. So sepsis is a very dangerous condition for people that are hospitalized, and about in the hospital where the trial was run, about 7% of the patients developed sepsis during their hospitalization, and the system failed to pick up almost 70% of all those people who developed sepsis, but it did give an alarm in 18% of patients. So there were a lot of false positives, a lot of false negatives, which led to a situation where, you know, if the alarm kind of went off for a sepsis case, it was only a correct alarm, let's say, in 12% of cases, which meant that the physicians in the end, you know, they had like alert fatigue, and they didn't really respond anymore to those alerts. And at the same time, many patients were treated for a problem that wasn't there. So I think that all shows that if we, you know, going to this complete automation is probably not a good idea, because the predictions of an AI oftentimes are not perfect either. We really need to have a clinician to make a judgment on time.
Excellent. And moving on, how does it work right now for informal consent of the use of artificial intelligence in clinical care?
Well, there are, I guess, different opinions on this. So we have in the European AI Act, it says that if people are confronted with an AI, they should know this. And the idea is that if I'm talking to a chatbot, I should know that it's a chatbot. I should not be thinking that it's a person. But at the same time, this is not directly transferable to health. Well, it would be if I would actually think that the physician I was talking to was a real person, whereas it would be an AI. But if it's about my physician using a clinical decision support system, It has been argued that there are, and I tend to agree that there are good reasons to inform the patient that you are using an AI and what the potential problems are in terms of bias, for example. I think especially if you have a patient that might not look very much like the kinds of patients that the AI was trained on. So if I know that the system is trained on, let's say, Caucasian males between 30 and 40, and now I have an African female of 70 years old, then I might want to tell her, well, my AI system, my clinical decision support system is telling me that this is the best treatment for you, but actually I'm not sure because this was trained on. So it would be nice if people would get that information. At the same time, if for each and every, let's say, little artificial intelligence part in the entire system, you have to inform the patient, then I'm personally also a bit scared that we might be scaring off patients, that they will think, oh, why are they telling this to me every time? This must be that AI is something really terrible or really problematic.
What's behind?
Yes, yeah. So it's a difficult balance. I'm also a bit wary of like AI exceptionalism, because we don't know when a physician gives us a diagnosis. I don't always understand either why they give me a diagnosis, and so maybe I might not understand with AI either. So I guess we will have to find a good balance here. With sometimes I think it is good to inform patients, especially also if it's really if you're going to use a robot, for example, in your surgery, and you have the chance of there being a power outage, then you might want to inform your patient so that you can get a valid informed consent if they are willing to take this risk or not. Let's say that it's, you're in some kind of crisis situation. So if there's really a risk of harm due to you using this AI, then I would say definitely people would have to be informed so that you can get a true valid informed consent. But I can also imagine that some AI tools could be implemented without explicitly telling the patient.
Like, for example, what do you think about an echography machine that has use artificial intelligence to gather information or providing a better echography, or a colonoscopy machine, for example, that use AI to scan, for example, the patient? Would it be your feeling about informing or not the patient? Obviously, being the physician being there and executing the actual exam.
Yeah. Well, I think the ideal scenario would be that the physician would mention this to the patient. But I don't know if I would, as a legislator, let's say, if I would mandate that we need a written informed consent for this to be used in every patient. But I would like to be informed as a patient personally. So it would be, I guess, good clinical practice for physicians to mention this. That's my good feeling.
Yeah, it makes sense, because also we think about artificial intelligence, but for example, they never tell you how old the machine they're going to use it is, or which is the brand, or which is the latest, the things that can perform, like that you're going to have an echography, and more or less that's it. So yeah, I think that there should be a boundary at a certain point, and also too much information sometimes it's not maybe the best course of action.
Yeah, then you're overburdening the patient as well, right? And I think you are right that we shouldn't be exceptionalist about this. And it doesn't matter. I mean, I don't want to say that maybe we should be informing patients more about the fact that the machine broke down last week, but we should be careful not to make like a completely distinct category for AI, whereas we are not holding other tools to the same level of scrutiny.
Accountability, yeah. At least, obviously, if our audience disagree with us, please let us know. We will be really keen on knowing, because we also want to sparkle a debate and know what the patient community thinks. Moving on. Oh, wow, that's exactly the moment where we are going to ask our audience. So we have a second poll for you exactly about this. So I'm going to launch it. So would you like to be informed if your doctor is going to use artificial intelligence during an exam? You have 3 options: yes, no, or not sure. You have few seconds to vote. Okay, so let's see how we're doing. Well, I think gonna close the poll. I think it's quite obvious. So 94% say yes,
Yes.
with no doubt.
Okay. Yeah.
6% say that they're not sure, and no one say no. So I think that's quite
so it's a clear message. Yes. Yeah.
that's quite something.
See the results. Yeah.
Excellent. Finally, I managed to share then.
Yeah.
Okay, I'm gonna hide, and we can go back to our questions. Thank you so much for participating in this little poll. Yes, so getting a little bit more technical here. What are AI predictive analytics, which is a bit of a buzzword lately? So if you can enlighten us, that would be very helpful for us.
Yeah, well, it's actually not that complicated. Well, to explain it, to do it, I don't know. But it basically means that you are, based on a lot of information on previous patients, you are going to make a prediction about a new patient. So you are going to, as I said before, in the case of Thomas, you're going to link characteristics of this new patients to all patients to make a prediction. Of course, it's not a 100% correct prediction in most well, the great majority of cases. So it's rather going to be, you have an increased risk of developing this or this, or yeah, you have a 40% chance of heart disease, or so, depending, or if you're already in the hospital, we think that you might have a relapse later on based on the profile you have, those kinds of predictions. Yeah, that's basically it. So it's very, well, simple, but not simple, I think, if you get a diagnosis like that, because it's of course difficult to know what to do with that kind of information. What do I do if I have a 30% chance of heart disease? Is it
a lot? Is it not a lot? Yeah, what does it mean in practice? And yeah, no, absolutely. Yeah. And do you know if they are already using this, for example, in Europe?
Yes, I do think so. There's well, I have a yeah, you can't really see it well, and I thought I put it on a slide, but it won't be that obvious. But it's for example, in genetics research, this is quite common already, I think, where you can know if somebody has a certain genetic mutation, and this genetic mutation in the past has been linked to a certain genetic condition. Then if you pick it up in a new patient, you will be able to make a prediction. Yeah. And then if you can attach this to more data points, the better your prediction will be. So if you can make sure to enter, so for example, if you have genetic information and you have lifestyle information, you have food intake information, you have previous family history, then the more information you have, the better your prediction will get.
Excellent. So what are the ethical implications for the use of AI predictive analytics in healthcare? Yeah,
well, I think there are a couple. So one potential problem, you might say, is that if we go towards a healthcare system where we use more and more of these predictive analytics and try to invest more in preventive medicine, for example, to make sure if we can predict what somebody might develop, they might act more preventively, is that you get this concept of the healthy ill. So where I'm actually perfectly healthy today, but I have this this vision that I will develop something in the next year, or the next 5 years, or the next 10 years, and therefore I start becoming a patient even before I'm actually ill. And if I have, let's say, a 70% chance of developing an illness, that's a high percentage, but it means that 30% of the people who would get a prediction of you have a 70% chance of, it would be wrong. So if they start acting already as if they are ill, if they're starting to take medicines or food additives or whatever to prevent this potential illness from materializing, then yeah, we are doing a lot of over-treatment, of course. So that might be one negative effect, let's say, of these kinds of analytics. And then also an important one here is, again, bias. And maybe if you can show the next slide, then I can illustrate this. Sure. So this is from a study, what we call a GWAS study, so a genome-wide association study in genomics. And the samples that are in this huge databases of GWASs are mainly samples of people of European ancestry. So if this would be representative of the entire world population, then there should only be like a little tip of red in that. The one you see on the right is the global population. So then we should have mainly East Asian patients and South Asian patients in our database. And then what is maybe a fifth or a sixth of European ancestry, and then about an equal amount of people of African ancestry. But what we see is that in these genetic databases, it's almost all European people and some East Asian. So if you then look at the right, if I would make a prediction based on this information, and let's say that the prediction, they just put European on, let's say 1, so that's the reference. If the prediction would be would have a validity of 1, let's say for someone of European ancestry, then it would be much lower already for people with different ancestries. And especially the purple one you see all the way to the right is people of African ancestry. So their prediction would only be 1/4 as accurate as for someone with European ancestry. So if the chance of a prediction being correct for me as someone with European ancestry would be, let's say, 50%, then for someone with African ancestry, it would be less than, or it would be a bit more than 10%. So it would be completely different. And if we are going to act as if we are going to, let's say, sell these kinds of genetic tests to people and say, look, we have a predictive model, we can predict what you will have based on your genetic profile. But actually for this particular patient, it's not representative because it's based on samples of people with a different ethnicity or with a different gender, or a different sex, because that's the similar problem. Then of course you will get very poor predictive analytics. And I think sometimes people tend to forget this, that they really have to tailor the information they give to the patient. And it's also problematic, of course, because as a physician, it's also difficult to say, well, I have this genetic test, but well, you're not of European ancestry, so I'm not going to perform the test in you because it's useless anyways, and I don't have an alternative for you. That's also, in terms of fairness, also a problem.
Yeah.
So that is a problem, I think. And then even if we would be and maybe I'm being a bit too paranoid now, but even if we would be able to give very good predictions of people, I'm not so sure that patients or civilians or citizens would actually act upon it a lot, because we know from a lot of research that, well, basically we all know that we have to eat healthy, we shouldn't smoke, we should do lots of exercise. But well, if I look at myself, I've been sitting on a chair all day. I know that it's not healthy. I know it can lead to a bunch of health problems. I'm perfectly informed. I don't need a genetic test to tell me that. And yet I haven't been exercising today. So we can also wonder, even if we have all this high tech for predictions, we will need something extra. We will need to be able to, make sure that people also act on it. And that's maybe the step that we sometimes forget about when we think about how great this technology might be.
Yeah, and then looking at the other side, I was thinking maybe someone that is more fragile from a mental health perspective, it could also live with the burden. And ethically, I don't know, for me it would be complicated also as a physician to assess if the person can live with a certain burden on knowing that probably will develop a certain condition, or if this would put like the person 10 next year in a very dark maybe atmosphere, maybe for nothing, maybe for good, but still, as you say before, living as a patient already when the person is not sick.
Yeah, I think it's true, and especially we tend to forget how common diseases are. So even if you get a risk score, I know that there was a paper not so long ago that was in the reproductive atmosphere, so of embryos being screened, and then there were 5 embryos, and you got all these scores per embryo, also based on GWAS studies. Like this embryo has a 30% chance of hypertension, this one 20% chance of diabetes. And in the end, the parents decided not to transfer any of the embryos, even though several of them were well within the range of, they were average, but that meant that they had a lot of predispositions, because we all have predispositions. We're all going to get ill and we're all going to die, unfortunately, one time. So, but people don't like to have that information specified sometimes. It's nicer, I guess, if it's all vague, that we know, well, at one point we will be in a hospital someday, but it's more difficult psychologically if you know, well, or if you can assume that it will be for this or this condition sometimes. Which doesn't mean that preventive analytics is bad, because sometimes you can really prevent really horrible diseases that way. So again, I don't want to only focus on the negative, but it is something to take into account, I think.
Yeah, and use it mindfully and when really necessary, and not like, as you were saying, yeah, lighthearted, let's say.
Yes.
But I'm sure we will have more questions on this later on. Yes.
Yeah, because I'm talking a bit too much. I think we won't have much time for questions. I'm sorry.
No, but you had also a few. No, I think you're talking and people are listening fully, because it's incredibly interesting. You had also here a couple of more examples.
Yes, just to show how to say it, how difficult also sometimes it must be to bring a predictive message to a patient. These are some articles on predictive models on depression. So one is just based on Instagram pictures, and the other one is based on questionnaires that students have been filling out. And there are ways of telling a person, or saying of a group of people, in this group of 100 people, let's say 70% of them will have, for example, suicidal thoughts within the next year. So you would think, oh, we have to, it's good that we have this information, that we can do something about it. But how do you approach these people? If, for example, if these are students that have filled out a questionnaire, and now well, 7 out of 10 of this group will develop very severe depressive and suicidal thoughts. Well, are you going to write them an email and say, well, you have a 7 in 10% chance of becoming? It's not as easy as it seems. Also, you are going to write this email to 3 people who would not have developed this, and who might start thinking, oh, well, what's wrong? Should I be depressed? Should I, is there a reason for me to worry? So especially, I think when we think about psychological, mental well-being, we have all these great tools to predict things, but sometimes the clinical implementation is certainly not straightforward. So that's also something I think we have to work on and think about, because you can change your threshold. Of course, you can say we will only contact that group of people that have a 90% chance of having really serious depressive symptoms, but then you're missing a lot of people as well. So there's always a benefit and an advantage and a disadvantage if you want to target more people or less people based on a predictive analytic.
Yeah, no, absolutely. And you touch upon a little bit on this, but what are the ethical risks of bias of artificial intelligence? Just to summarize, if you.
Yeah, I think I already mentioned quite a bit of this, but maybe if you can go to the next slide, there I have this example that I briefly already said something about. But this was an algorithm that was developed for hospitals to calculate which patients are more likely to spend more time in the hospital. And the idea was, if we look at the patients that have characteristics of people that spent a lot of time in the hospital in the past, these must be the most ill patients that we should pay most attention to and give most care to. But when this algorithm was evaluated, what was noticed was that those patients that were flagged as being seriously ill, if they were white, they were usually a lot less ill than if they were African American. So what happened here is that if you look back at the past, many African American patients in the USA don't have access to healthcare, so they can't afford to stay in the hospital for 2 weeks if they can also, manage to go home after 1 week. Whereas more of the Caucasian people, the white people, were able to stay there a week longer because they had better health insurance. And then if you feed this into your algorithm, or if your algorithm, again, not being racist in itself, of course, but if it learns that, well, people that have a certain ethnicity or that have a certain postal code in this case, they tend to stay in hospital for a shorter period of time, so they must be less ill. Well, that's a wrong conclusion. And there, in this way, you can reinforce already existing this discrimination in the healthcare system. So in this case, if they would have corrected for this bias, then the percentage of Black patients that should have received extra care because they were in worse condition increased from 17% to 47% or 46%. The positive side about this story is that it was corrected, so it can be picked up if it is explainable, if it is transparent, if it is. So that's I guess the upside, that if we're conscious about it, and if we check the systems, which also requires the people who develop the algorithms to offer transparency so that people can look into it and can find where the bugs are, let's say.
Yeah. What fascinates me, and moving on to the next question, is that actually there is a lot of work to do on the human side as well, on our own bias, I think, to be able to create a fairer artificial intelligence learning machine. So this is really, I think, fascinating also on an ethical perspective, right? It's also a challenge for society to be more mindful of our own personal and collective bias in a way.
Yeah, I think in a sense it shows us a mirror also of
yes.
what we're already doing, but now we see it more clearly even.
It's a bit more in our face in a way,
yes,
in the consequence.
Yes, because it's amplified more and more. Yeah.
So we're getting towards the conclusion, but what can patient and patient advocate do to tackle all these challenges that we've been discussing on ethics in artificial intelligence?
Well, a number of things, I think. Well, advocacy is a very important element here. So I think patients and patient advocates can advocate for more oversight of AI to make sure that it takes into account patient values, that it's, for example, I didn't show that example now, but there are systems that are made to make sure that, for example, no-show patients are overbooked, which then results in already vulnerable categories of patients getting less care because they will only have half, if they do show up, they will only have half the time for a consult. This is not in line with patient values. So we should be careful that when we build an AI system, that it's not built on commercial values, but on patient values, that the patient well-being is the main and only outcome in the system, preferably. That fairness is taken into account, so that the bias, and especially bias against already discriminated against or parts of the population, they are remedied somehow. This, for example, also goes for it doesn't have to be minorities, also for all the women. Many of health research is being conducted in men. So if you enter all that information in your AI system, then it's not going to be very good for women. So we should really make sure that things are corrected for unfairness, that we make it more fair. I think we should advocate for transparency and explainability, so that there can be some kind of quality control of algorithms, that this is not under IP, intellectual. Well, some things can be under intellectual property, but if it's the health of patients that is at stake, then we must have some way of checking if a system, how it works and if it works properly. Like the sepsis example I gave, that was proprietary information, but they tested it just in a new hospital to see if it worked, because they couldn't look into the data that were generated to build the system. Accountability and trustworthiness are important words there as well. So if somebody, accountability is difficult oftentimes in AI, because the responsibility is very diffuse oftentimes, how a system is built and how it works. But it is important to stress that you have to build tools that are trustworthy, that are reliable, and that are in agreement with our patient values, so that we can, as a patient, trust that the system will work to our benefit and not harm us in a way. And then I guess the last one would be security and safety, that we can check if it's not leading to any harm.
Okay, well, we are going towards the last question of this marathon, so brace yourself for the last one. Why does the introduction of artificial intelligence, machine learning in healthcare require research on big data in few words?
Yeah, I think I already basically covered this. It's the more data you have, in principle, the better your AI system will become. The more, and that is the advantage that an AI system has over a physician. It can deal with a lot more data than a person can. So that's the strength, let's say, of the AI. But that's also why we need to share patient data or health data with researchers so that they can build AI systems that are based not on a small subset of data, but on a huge set of data that is much more representative, especially when we're talking about rare diseases, of course. Whereas now, if you have a rare disease, your physician is not going to have a lot of expertise because there are just not many people with your condition. But if you can gather all this data, worldwide, and have an AI system study what the relevant elements are, then you might get a lot further.
Absolutely. And well, that was really our last question, and I think it's really now time. We've been a bit chatty today, so we might have a lot of time. No, not at all. Few minutes, only a few minutes for questions. So it's really your time, dear audience, to fire any questions you would like to ask Professor Mertes. And please do so Friday in the chat. We will be able to see your questions and hopefully answer accordingly. And I had a question that we received over email while people take the time to digest a little bit what we've been talking about. And I have a question related to data triangulation. Maria from Spain wanted to know what data triangulation does it mean?
Yeah, so data triangulation is where you, if you do a research, where you use different research methods and obtain different kinds of research data on the same issue, on the same problem. And then you can kind of approach the problem from different angles and compare it so that you have more solid conclusions. So if I would only do, let's say I want to know the patient's opinion on a certain on AI, for example, I could do a questionnaire and ask people a bunch of questions. So then I have quantitative data, but it might be that I forgot to put something in my questionnaire. So if I also do qualitative data, if I talk to patients in a focus group interview, for example, then I will have different kinds of data that I can join in with my, so qualitative data, I can join in with my quantitative data to come to better, a better view on what the answer to my research question is, let's say.
Excellent, thank you. And I see a lot of people thanking you for the very thorough answers to all the questions, and people sending greeting from Stockholm, Sweden, saying it is snowy, and in other places. I have another question, and then I think we can close if there are no other further questions from the audience. Something that we touched upon at the beginning, but I think as a word that we saw quite a lot outside, is that what does it mean, behavioral data surplus, and where do we mainly can come across that, and why should patients think about it when being called, for example, in discussing AI applications about it?
Yeah. So the surplus already says a bit of it. So it's data that you are supposedly not looking for, but that comes with, that you do gather. So this is, for example, a concern in, or a phenomenon when we're thinking about social media, etc. For example, so you might be gathering information on yeah, on one topic, but then you get also information about someone's food habits or about someone's exercising habits, or so all, you know, behaviors that people have, which we might interpret as very personal information, and which is kind of like an add-on to information that you might have been looking for in first instance. So you might say, well, I didn't mean to, you know, to look at what you're doing all day. I just meant to have information on something else, but it's information that comes on top, and that sometimes is used very well, very eagerly, I guess, for commercial purposes. For example, if somebody knows where I shop and what I buy, if they notice that I'm, you know, that I'm buying baby stuff, then they know she must be a young mother, so maybe I can sell her this or that, or especially also, for example, in politics, if you know what kinds of things I click and what I do, then you might know my political affiliation, you might know what kind of messages I'm receptive to. So that's more outside of the healthcare setting, but that's where this, for example, also comes up.
Yeah. Absolutely. Well, thank you very much, Heidi. I think that was really our last question. We just wanted to give you everyone a heads up. Our third webinar will be in next year, actually, and we will be discussing something that we touched upon very briefly today, the AI Act and other legislative processes that are being developed at European level. So we will define a date, and the webinar will be, the European Commission will be also joining this webinar, so stay tuned. And obviously, Heidi, you are very much welcome to join us as well if you would find it useful for your work. And once again, really, really thank you for taking an hour and more for the preparation from your busy schedule. We really, really appreciate it, and I hope this will be one of many collaboration that we will have in the future. I also wanted to remind our audience that we do have on our website the AI Knowledge Hub, which is actually a repository of papers and publicly available articles, webinars, and other resources for you to learn more about artificial intelligence in healthcare. So please do take a moment to surf there and see what you can find helpful for your organization and your work. And Michele is kindly putting the link in the chat, so you can directly link it there. And obviously this is supported by the AI fund that is developed by the network of European foundations. Well, that was really all. Thank you so much for being with us for an hour and for taking the time from your busy schedule to learn more about artificial intelligence in the ethics application. We hope that this will be useful for you, your organization, and your members. And really, really big thank you. And it's my moment also to wish you a fantastic holiday season coming up. And we'll resume our webinar sessions in January. Thank you, everyone. Thank you, Heidi. Thank you, Michele, for the technical support. And thank you, everyone, for attending.
Bye.
Bye.